less in Indian patients as compared to their Western counterparts. So these are the studies which have been published in peer-reviewed journals. The cost, in fact, the cost of surgery, if you put in a lens, and because the aphakic patients have to come for repeated follow-ups. In fact, if you consider the blind person years because of aphakia as compared to patients with IOL, the effective cost in IOL patients is much less than in aphakic patients. Again, these are the studies. So what are the points which are in favor of IOL implantation at 6 months? So there is no statistically significant increase in complications. Glaucoma, in some of the studies, there is less incidence, less refractive surprises, especially the myopic shift is less in Indian patients because of obviously the better IOL formula, pediatric IOL calculator, and crisp surgeries by Indian doctors. Visual axis opacification is less in IOL group, better unaided vision in intraocular lens group. Indian surgeons have better surgical dexterity and experience. So there is better instrumentation, good microscopes, good OVDs. So obviously it is cost effective. There are less number of surgeries. So these are the various studies which favor lens implantation at 6 months versus aphakia. In fact, one of the neglected point is childhood blindness because of aphakia. In fact, Parikshit was one of the author in many of these landmark studies. So if you see uncorrected aphakia, that is one of the important cause of childhood blindness in India. And many of the patients, they are from the remote rural background. They don't come for follow-up. They're amblyopic. So the childhood blindness is more in uncorrected aphakia as compared to IOL group. So again, these are the various studies which favor IOL implantation at an early age. See the list. So I think that we should all understand the importance of time and the importance of time to change for the better. Because I would like to quote Roosevelt that future belongs to those who believe in change for the better. Because change is the only constant in nature and life, and change paradigms of infantile IOL surgery have changed the quality of life of those tiny tots for the better. So that's the importance of timely intervention. We should always respect the time. So I think with the permission of the chair, I would like to quote a famous share by one of the famous Indian poet, Bashir Badr, who tells us about the importance of time. तो वक्त को समझना समझदारी होती, वक्त को समझना समझदारी है, और वक्त पे समझना जिम्मेदारी. Thank you, Fagan.
Okay, so after 2 minutes, 1 minute. Yeah, okay. I think let's me hear from the house. How many people for no lens at 6 months? All right. And how many for lens? I think almost equal. Okay, so I think what they said is that I think anybody who's operating here, the first thing about the myopic shift, you have to follow these patients, whatever you're getting, especially the unilateral ones, because what you do is when you follow up, you have a cohort of the patient in which you know what is happening to normal eye vis-a-vis the growth of the eye. So we did a study at the RP center in which we took the patients less than 6 months, 6 months to 1 year, 1 year to 2 years. We followed each group for 6 months, and all, in fact, they're finishing 1 year. We realized that the undercorrection which we do, we don't need that much as the Western, what all these people are doing in the past. So IOL, and especially unilateral cataracts, contact lenses in Indian setup is a big no. The environment things. We had a guy coming over from Leicester who did some lectures at our place. He's got 205 patients in his entire career. 50% are unilateral with contact lenses. In that environment, yes, it works. In Indian scenario, you have a dropout of about a 7.3 contact lenses per year. So if you put the cost of that, it's mind-boggling. If Vicky glasses, I see he said rightly, the parents, the poor patient will buy maybe one pair. If it's broken, maybe the second pair. Third pair, I think they're iffy because they don't have money. So I think even if you leave a glass with a refractive undercorrection or overcorrection of ±2, you've still got a target. So what I think that 6 months, if you have everything with you, you're able to calculate the power properly, and you've taken the seismic indication into consideration, and you checked for the cataract glaucoma setup. Most of these glaucomas will happen if they were pre-operative only. There we have missed out. All these studies from Australia et al. Group, these people had talked about glaucoma. It was already there. Anterior segment dysgenesis. Those eyes are abnormalized. In those ones, maybe you can think about not putting implant. If the health of the eye, the size of the eye is good, any is excellence which is more than 18 millimeter, or white to white more than 10 millimeter, I think you can go with the lens. And doing an explant in these patients is not impossible task, and you're doing a justice to this patient, right? Okay, thank you.
Thank you. Thank you, Professor, for those really valuable nuggets. I would now request Professor Rohit Saxena to start the second debate. I would request all the speakers to stick to time, because even our inferior oblique speakers, which were not supposed to come, have also come. No, I'm not saying not supposed to come. We didn't get a confirmation from them. So they are also here. So we want to really fix it in time, because everybody has to be back here by 11:30 so that they can go to the next sessions.
Thank you. Yeah, obliques come obliquely. So I'll be talking about pharmacological control being better than optical for myopia. And we'll just see how the response comes from Jitinder. Basically, the fact is, as has been mentioned, there is huge evidence, and that's what we actually always would look at. So huge evidence on the great efficacy of atropine per se, and that is for over 50 years or so, that atropine has been proven to be effective in preventing progression in myopia, and low dose atropine in the last 20 years or so in significantly retarding the progression of myopia progression. Not only is it an evidence that it prevents that, there is a very clear dose-dependent response actually scientifically proving the fact that the drug is effective. In India also, so always we keep saying that maybe it's valid for the West and not for us, but even in India now there is adequate data available, including a placebo-controlled, double-blind, randomized, multi-centric trial that has shown the efficacy of about 50+% in reducing myopia progression over a year. There are very, very few studies on the role of myopic spectacles, and mainly DIMS, which has very recently come out with a 6-year data, very small, about 100 eyes, whereas the sum total of atropine data would be more than a few thousand eyes over 5 years. So we are actually talking about a huge data, huge evidence. There is no evidence among Indian children about the efficacy of these DIMS spectacles, and you can just compare the efficacy, 50 to 70% by most studies on atropine, and barely 30 to 40% by most studies on the spectacles. Affordability, India is a very price sensitive market. Atropine is way economical as compared to spectacles. It's about 7 times less costly. India, 50% of the population would have 10 to 20,000 as a monthly income, and to spend 16,000 just buying a pair of glass that can break, that can change in the next few months would definitely be a daunting task. So definitely patients always prefer atropine. It's easily available. You just go to any pharmacy, you have a prescription, you can easily buy it. In fact, sometimes when we write atropine ointment for refraction for our children, they come back with low dose atropine, because that is the push of the market. So a lot of pharmaceutical companies, India is leading the way. We should be proud of our Indian pharmaceutical industry. Before America, Europe, Africa, rest of Asia, India has been pioneering and has actually sending these drugs across the world, including the European market. Getting commercially DIMS or any of these spectacles is a challenge. Only few and very expensive shops would be having it. They need to center it well, they need to cut it well. There are a lot of issues in this, and just in case the child is uncomfortable, the parents are really tearing their hair on the cost that they have spent with very little return. There is no special frames, no techniques, nothing when you're worried about atropine, because you continue to wear your single vision glasses. But here again, prescription is important. You need to be very accurate when you're prescribing, and of course the various frames, it should be larger frames, because that's how the mid periphery is going to be effective when you're looking at the effect of these DIMS glasses. There is a lot talk of peripheral refraction that is going on, although there is no clear evidence that it is an important thing. But then these lenses work on the concept that there is peripheral hyperopia in these children, and therefore you should actually be only prescribing them in children who have peripheral hyperopic refractive error. So again, this is not something that is easily available. In fact, even in our center, we we're just struggling to acquire something like this. Atropine is approved for now over 3 years. DIMS and all these spectacles have no approvals in India, at least at the moment. So they are officially off-label use. So, I mean, I would say there is no doubt as to the best available option that I would offer to anybody I know regarding their use in myopia progression. So thank you very much.
Thank you so much, sir. So when sir says you have to use this, you have to use it. You don't have to question his intelligence, his knowledge at any point of time. I have worked under him also. So yeah, I mean, if he says that atropine is good, atropine is really good. There was, I'm not arguing that atropine is not good. In fact, few years back, okay, so I was trying to unhide some slides because of some of the things which he said. I had put it, but I had hidden them, thinking that that will not come up. So I will show you those slides also. So the first and foremost point is that, you know, compliance is a huge issue. If you have your own kids in whom you are putting atropine, I'm pretty sure it will be a tough task when it comes to compliance. Glasses, compliance is not an issue. So cost is definitely an issue, and that is why, which one is better? They're complementary to each other. We just presented our paper yesterday saying that in patients who are not responding to atropine, this is a good idea, because once you have, you know, shot all your arrows, what is there in your armamentarium is DIMS or Stellest. And there is, okay, for atropine, I have been using atropine now since 7 years, since 2014. I used to reconstitute it. We presented our paper in 2018. I definitely agree with him that I have more than 1,500 patients on atropine, which is a huge number compared to what DIMS is. Obviously, it is a new thing, so numbers would be less. There is no doubt about it. It's a new thing. It is expensive. Most of the multifocals, when they came to the market, there were a lot of things which came to the market which were very expensive. We are using them because they are effective, so we are using them. So there is an evidence here that how DIMS works. At least there is an evidence. In last 8 years, we have been trying to find out how atropine works. We are yet to find out. Three years back, I was on the other side of the debate with one of my teachers. I was talking about low concentration atropine, and sir was talking on whether it works or not. And my final line was the damn drops work. So I completely agree with him that atropine works. What is next to atropine? Atropine is there. There is no doubt about it. That is the benchmark that has to be started when there is a myopic progression. The word is myopic progression. So these are some of the studies. 2 years, you can see there is 2 years clinical trial rate. I mean, there 2-year follow-up, 6-year follow-up. So it is not new. It is new in the country. It is not new to the world population, because India is a cost-sensitive thing. So they have introduced it late in the market. How does it work? It works on the theory that, you know, so basically the peripheral retina is responsible for the eye growth. That is the theory which was given by Earl Smith. And that is what was being questioned, because it has been done on macaque monkeys, not on humans. But this is the DIMS lens we are talking about, 6 years experience. This is how it creates a myopic defocus, and that is how it controls. This is the data. Since I knew we will be talking about the data, so this is the data. 2020 they published their 2-year follow-up. 22 they published their 3-year follow-up, and they published their 6-year follow-up. Now there are a lot of holes in the study we can find in most of the studies, because most of the authors who have published these studies, I'm countering my own this thing, but most of the authors that have published are on the board of research committee of Hoya. So we have to take everything with a pinch of salt. My own experience, I have used it in 10 patients of non-responders to atropine, and it has worked in them at least for a year. I don't know how it will be in the future. Why 10 patients? That was the question which was asked by the judge, because it is very expensive. I mean, we are in private practice, it is expensive. So yeah, there was a point that how to do peripheral refraction. Just this is what I have drawn it myself in my OPD. We tried to make a new device so that it becomes cheaper to measure peripheral refraction. And this is what we came up with. This is with a 3D printer. We made a small attachment to the retinoscope. And this is the, can we mute the sound? Thank you. Thank you. So this is the device. You can attach it on the retinoscope. This will measure 22 degrees temporal and 22 degrees nasal for you. So this is a simple device. You can, and one of the good articles is that, you know, whether you turn your head, your eye, it doesn't change your peripheral refraction. This is published in ophthalmology, physiology, and optometry. So you can move your head, you can move your eyes, but you need to find out 20 degrees, 30 degrees temporal. This particular attachment measures exactly 22 degrees temporal, 22 degrees nasal. So those are my arguments. I would again say that, you know, it is complementary. It is not, I have never used it as a primary treatment to myopia progression. Thank you so much.
Thank you, Dr. Jitendra. Yes, sir.
So the ones who didn't respond to atropine, did you add these glasses add-on, or that you stopped atropine?
No. So
It's like an adjunct now.
yeah, I used the word adjunct. Pre-atropine, the progression was 0.86 diopters. Post-atropine, it reduced in these particular patients to 0.7. And since it was more than 0.5, we started on DIMS, and then it reduced to 0.3. But that is only 10 patients. There's a huge number of patients who respond to atropine. Yes, sir. We did not, because atropine has a rebound effect. So once I stop atropine, they will come back, and the glasses, we won't be knowing what glasses is doing. 6 to 12 years, sir. Yes. So what does the house say? Yeah, house. I don't know. Oh, sir,
What does the house say? I think
okay, how?
one side the parents are taxed, the others, I mean, the parents are taxed either way. Either you put the drops or you get the pocket chopped. So
No, so who all uses low dose atropine? And who has used DIMS so far? Yeah.
I think low dose atropine, lot of things we don't understand as of now. I think as a lot of research is going on in experimental and in human setup. So I think in another couple of time we'll be understanding a bit more how it actually works.
and the other
But
thing
it
is,
does work. There's no controversy about that.
yeah, the other thing is you can stick on to your retina colleagues. If they're seeing the ROP patients, when they do the lasers in these patients, mid-periphery lasers, those are the eyes which grow much faster. So that again is the peripheral blur which kicks in.
Very true.
So that's the most important thing. So we have a retina people who associated with us. So we switch over to their side when these patients come, and we realize they can go out of proportion. Those eyes you just cannot predict. If you've done half laser or full laser all around, it will make a difference. So I think there's so many things we don't know how atropine works. But yeah, the DIMS I think has more physiological optical basis.
Yeah. In fact, those who had laser and those who had cryo and those who had anti-VEGF, there's a lot of difference in what you were saying.
Yeah, the anti-VEGF group doesn't go that bad as the laser or the cryo group. Cryo nobody does now. It's a laser now.
Yeah.
Thank you.